here. So thank you everybody for joining us for the IBMS Support Hub. Delighted to be with you again today with Tamina, who co-hosts all of the support hubs, and we're delighted that we have some colleagues joining. Chris Ward, who looks after our advanced and higher qualifications. We've got Jane, Rachel and Monica, who are all going to talk to you about being a consultant biomedical scientist and their experiences. So thank you so much. Feel free to put any questions in the chat as we go along, and I will unmute people so you can ask questions at the end if you would like to. So over to you, Chris.
Thank you very much, Sue. So yes, welcome everyone. So Chris Ward, the Head of Examinations at the Institute, and Jane and I are going to do a double act here in the best tradition of a COVID briefing on there in terms of going through the various slides that we've got. So I'm just going to share my screen and then we'll make a start with the presentation. So bear with me a second as I bring it up. Could just someone shout that they can see the presentation? Hopefully they can.
Yeah, can see it fine, Chris.
Thank you, Sue. On there. So welcome everyone. So yeah, the idea this morning, so this lunchtime session, is to have a talk around the role of the consultant biomedical scientist, both looking at what we've done so far as Institute and our current plans or future plans for the work that's going on as well. So Jane and I are going to do a talk for the first part of it, and then got a couple of colleagues that Sue just introduced you to who can talk about briefly their experience of becoming consultant biomedical scientists. So that's the plan in terms of the session for today as well. And happy to take those questions that any rise during the chat afterwards as well, and put it in there as well. So we're going to start with some background to it, and that's just what I'm going to hand over to Jane to talk about the background into the work of establishing consultant biomedical scientists. So Jane, over to you.
Thank you very much, Chris, and hello to everyone. The background for establishing a consultant biomedical scientist, has been in discussion for a number of years. But as we all know, the pressure on the NHS now, with the growing numbers of patients that need acute care and the long-term chronic healthcare needs of an aging population, has really highlighted that we need high numbers and lots of numbers of highly experienced staff, and we need to make use of all the knowledge, skills and talents that we have in our workforce. And one of the key to delivering this and meeting this demand is having a highly trained, experienced, multi-professional workforce so that we can bring all our skills together. And within the clinical laboratory diagnostic service, there's been a number of reviews now that have highlighted shortages of medically qualified consultants. And on the back of that, it is recognised that consultant scientists are often well placed to help fill these gaps, both within the laboratory diagnostics or direct patient-facing care roles, or a mixture of both. Next slide, please.
Oh, yeah.
Okay. So following on from the NHS workforce plan in the early part of 2023, hopefully you've all had a chance to have a look, but the IBMS launched the long-term biomedical scientist workforce plan last September, which is a really comprehensive document which put out a very bold strategy within the United Kingdom to develop the biomedical science workforce to operate at the highest levels of practice, which they've gained through training, experience and professional qualifications that would take them throughout their career. And this is the first time we've really had a document like this within the IBMS. And it's a valuable benchmark to actually look where we're going and future planning of our qualifications. Next slide, please. So, as I said, within the plan, it covers all aspects of a biomedical science career, but I just want to pick out elements of it which are directly related to the topics we're talking about today. So within the plan, it's encouraging the development of advanced and consultant level practice for scientists working in the NHS across the UK. So it's got to remember it's important to know that we have, with the 4 nations, that healthcare is devolved across there. So we need to be careful that it's applicable across all 4 countries. What we have realised is that acceptance is still at a slower place within the field of biomedical scientists compared, for example, to nursing and AHPs. Nursing in particular have sort of started on advanced practice and consultant level practice quite a few years, and have got a lot of experience that could be quite useful to us in developing our roles. The NHS England has been instrumental in promoting such posts for us and the benefits of patient care of introducing advanced and consultant practice for biomedical scientists and how these roles could be applied across all pathology disciplines. And within this includes increasing capacity for diagnosis and treatment, and this monitoring through either direct patient care routes or indirect patient care. And we now know that healthcare is delivered in many settings. So we're looking at sort of both primary, secondary and community diagnostic hubs. Next slide, please. I just wanted to put a quick slide in for clarification, because with a lot of developing practice and new areas, vocabulary is quite important. And the terminology that we use, say, within our professional setting, doesn't necessarily mean perhaps quite the same thing in other professional groups. So I just think it's important just to be conscious of the use of words, the use of titles, and the environment in which you're participating in. So if we look at advanced practice, this is delivered by, looking at various definitions, experienced registered healthcare practitioners. It's a level of practice characterised by a high degree of autonomy and complex decision making. And in general, in terms of an academic equivalence, this sort of level of advanced practice is looking at sort of M-level academic knowledge and skills. Hand in hand with any role like this, there's obviously all the experience and knowledge which comes from your work in practice. But as I said, from an academic point of view, you're looking at M-level qualifications. The consultant practitioner role is obviously above this, and this requires post holders to deliver highest level of expert clinical practice within their specialty and to lead within the profession and their speciality in practice, and also to have roles and experience and deliver high levels of knowledge and skills within education and research. And again, as an academic benchmark, one is looking at doctorate level for this type of role. So I hope that's just for clarification, because I know often the words advanced and consultant come in the same sentences. And if you're working in committees with other professional groups, just to be clear that when you're talking to other colleagues, that you're actually all on the same page. Next slide, please.
Thank you, Jane. And just so briefly from me now, one area that has been raised perhaps as a concern by some people is around whether, as biomedical scientists, you can act in these roles. And it's worth saying that literally in the last month, the HCPC have issued an updated statement on advanced practice. And it's a fairly lengthy statement, but it's based on a lot of research that they've undertaken on there. But in short, there is no statutory or no regulatory barriers for you as scientists to undertake advanced practice roles. You are working as registered biomedical scientists. Obviously, therefore, you've got the standards to maintain in terms of that and meeting those standards. And if anything, you weren't to meet those standards, as much as any scientist would be, could be pulled up by the code of practice, that applies to advanced practice roles as well. So the HCPC have recognised that, and I think that's an important point, because on there that there isn't a regulatory barrier for you acting in these roles. They do recognise, and a bit like James just mentioned here, that there is still some work to do in getting a common understanding of what advanced practice is and have a shared understanding of that, whilst recognising in the different regulatory professions that the HCPC look after that there'll be some variation, but to have a common understanding whilst not stifling innovation or development of such roles as well. So that's a a quick way of saying really that there are no barriers from the HCPC from you undertaking these roles, and that's an important part, and that also helps us as the institute in the development of relevant qualifications. And some of us exist for a while, some of us are newer in terms of these type of roles. So I'm going to hand back over to Jane now. We're going to talk briefly about the different type of qualifications that are around in this area or are being developed. So Jane, over to you.
Thanks, Chris. Right. So just moving on, developing IBMS qualifications. I've started with histopathology and cytology, and I'm going to stop at that point because we've got two highly experienced expert speakers coming a little later on in today's presentation. So I'm going to let them talk on that. My background is haematology and predominantly hemostasis and thrombosis. So the next few slides have got to reflect this area. But again, we look at it more broadly across the other pathology disciplines as well. So in recognition of the expanding pressures within haematology services and the need for high level and highly specialist training programs to support medical colleagues, the IBMS has now launched two new diplomas of expert practice, DEPs. One of them is in hemostasis and thrombosis, and the other one is in red cell disorders. There is also a similar one in the process of development for microbiology, which will be available, I think later, possibly this year. Chris will correct me if I'm wrong on that one. And the potential benefits or choice on these qualifications is that DEPs could provide an alternative. It's a more clinical based qualification to the higher specialist diploma. So depending on where you think your career path may go and where your aspirations are and interest, it might be that you consider doing a DEP as opposed to the higher specialist diploma, or it might be you decide to do both. But there is an option there now within haematology for slightly more clinical based qualifications. Next slide, please. So I just wanted to touch on sort of consultant level practice, some sort of real world examples. To be clear, I'm not going to go through individuals roles specifically. What I've done is look across colleagues that I've known in roles and the sort of scope and areas of their practice, so that I've done a sort of cumulative slide of the sort of aspects that they've been involved in. And this hopefully will give you a flavour for those of you that are aspiring perhaps to go down a more clinical route either now or in the future, the sort of aspects that you might consider. So I think the first thing I'd like to say is that biomedical scientists have been delivering consultant level practice for many years, but not necessarily with the title, because there are many biomedical scientists that really have a very high level of expert knowledge in the fields they practice in. Within haematology, the roles have certainly been developing over the last 10 years, but it's important to focus that these roles are very much according to local need. They don't come about in an ether. There's got to be a justification locally for how these roles are going to complement the service and benefit patients. The roles are also quite diverse because they capitalise on the individual knowledge and skills. So if you've got an individual that is now moving into this type of role and there's been a service need identified, then the role they perform is going to be very much modelled around where their skill set lies. So there isn't a sort of a one job description role for these types of posts. There'll be core elements, but they are going to vary depending on the local application and local need for it. Many of colleagues who have been in these roles either in the past or now, obviously, a major part of the expertise come from your day-to-day practice, building on knowledge from real-life experiences. But also, there is a significant number that have also gone down the route of gaining a professional doctorate. And just as a sort of sideline, because sometimes it's not an aspect that perhaps people think about, but if the role you're in is moving into a more patient-facing aspect of the position, then there are courses, things like history taking and physical examination training, which is open to any healthcare professional. So if you're actually seeing patients, then this is something that might be beneficial. When I took the course, I was the first scientist they'd ever had on the course, which was quite interesting. But it certainly says something that if you're going to be seeing patients, it's something that you might find interesting to do, and also gives you experience on talking and dealing with patients directly. Next slide, please. So just as a sort of general covering of haematology, sort of colleagues in these roles, then the areas that they've been looking at and have been covering, I mean, one of the key things is their expertise in leading scientists, often in morphology and hemoglobinopathies. That's obviously an area where there's a massive amount of knowledge and practical experience involved, but it's obviously really critical to the diagnosis and future treatment of many patients. And it's an area where consultant level practice is really, really valuable. As part of delivering roles, and again in terms of contribution, consultant level practice involves active contribution in MDT meetings. So these are multidisciplinary team meetings where individual patients will be discussed and treatment plans, any issues. And as a scientist working at that level, then it would be expected and you to sort of actively be contributing to this type of session with the multidisciplinary team members that you're within your discipline. Providing training at all levels for medical and clinical staff, often representing clinical services at high level within the organisation or externally. Membership of national committees, e.g. quality assurance and specialisms. So again, it's all focusing on this high level knowledge and expertise. There should be elements of research and development, because often you're going to, if you're lead within your specialism, then either actively participate in research or being aware of research to bring in new services to the area is obviously important. And presentations at national and international levels, because again, not only are you participating and learning from others, hopefully at this level, you've got a wealth of knowledge that other people will benefit from listening and speaking to you. And other areas I've touched on before is direct clinical care. So within the laboratory diagnostic service, we often, our main focus is in direct patient care, because we care for patients, but we don't normally see them. But again, within haematology is a very clinical service. Within the haematology clinical service, there are hundreds, if not thousands, of patients. So as these role develops, and I say, depending on what the need, you may end up fulfilling a direct care role in some aspects of the work. And we've had examples of things like performing bone marrows. Next slide, please. So just to whiz through the different disciplines, again, sort of you'll see a similar thread. So we've got sort of expertise lead for scientists in the diagnostic service, again for hemostasis thrombosis, clinical interpretation and consultancy roles. Key aspect, again, at operating at this level is clinical leadership. So this will have management aspects of it, but unlike your laboratory managers, operational managers and pathology managers, this is very much, management is, for want of a better word, a small m, but it's embraced within clinical leadership. Again, education and training at all levels of medical and clinical staff, research and development. Again, membership of expert working groups and professional societies. And if you are going to be an expert in your field, you really can't work just within the four walls of your own organisation. You really have got to get out there, and as I said, other people hopefully learn from you, but you really need to learn from others and be aware of the latest development in your field of specialty. And as for haematology, again, indirect and patient care, we have a number of people in this area again that have had clinics. Personally, I've had clinics for quite a number of years, seeing patients with bleeding disorders. Next slide, please. And just to connect the trio, so we got the last one, sort of, but no means least, blood transfusion. And as we know, blood transfusion is really critical, particularly with everything that's come in the news this last few days with the use of blood products and blood transfusion. And so, we've got our consultant level scientists really are experts in safe blood transfusion practice, and there's never a time when it's highlighted how important this is. And again, clinical leadership with this is really critical, and particularly with transfusion committees, and how important within a clinical community as to the safe use of these products. I know the field of transfusion practitioners, I use this term quite broadly because I must admit I'm not up to speed on all the up-to-date titles of this. So if there's anyone in transfusion on the call who can shoot me down later, then please do. But for biomedical scientists, these are often, they may be laboratory-based, but often they're also ward-based or a mixture of both. So again, people in these roles are often direct and indirect patient care and running clinics to actually look at the safe use of blood, and particularly, quite importantly, is looking at their treatment options to actually avoid use of blood transfusion. And similar to the others, research and development, really operating at a national level, and development of professional clinical guidelines. Next slide, please.
Thank you, James. Over to me briefly for
Yes,
a few slides now.
on
there. So just to pick up what Jane was saying about the microbiology and the haematology qualifications, Jane's quite right. The Med Micro DEP should be available before the end of the year. It's been worked on at the moment. The hemostasis and thrombosis and the red cell disorders complement the routine haematology that's already available as well. And there's outline of those on the website already, and more information should be out on those in the next month or two on there. Just to pick up on other qualifications we're doing, we'll touch again on the dissection and reporting qualifications that already exist in a second. But in terms of other work that we're doing as well, there's work going on as we speak on a reporting one for the placental pathway. We've had for a number of years an ASD in ophthalmic pathology. Not many people have done it. It's always going to be a very small number. But again, some experts are working on revising that. And again, before the end of the summer, the revised version of that will be available, will become published. And for the dissection qualification, there's long been three pathways in gynae, lung, and in breast and GI urology. And we're looking to develop more pathways, or we will be launching new pathways in areas like gynae, lung, and GI, upper GI in the next couple of months as well. So more qualifications being made available as well. A couple more slides just to talk about the numbers of doing the qualifications to show where people have come through. So I mentioned briefly there about the reporting qualification. Rachel, when she talks later briefly, we'll talk about some of the challenges around it and her experience as well. But just to give you an idea, so far for the reporting qualification, we've had those who've worked through the different stages of the qualification. So the key one is really the bottom line of that, which is there's now, subject to 2 more being approved at the College Council in June, will be 29 individuals who have been awarded the final certificate of completion, and therefore are already or will be or have been working in consultant level roles. So you can see there's numbers going through that, and that's been quite a while, that qualification now, and building up, and the numbers are growing for that qualification. So good areas there. In terms of the other qualifications, we mentioned about some of those have been in existence for quite some time. So as I say here, since about 2005, more than 260 people have achieved the DEP, and some of those have gone on to then do the ASD in dissection. The cervical cytology has been in existence for a number of years in terms of that ASD. Obviously, there's been, any of you on the call will know, and Monika will certainly back this up, huge number of changes in cervical cytology in the number of years, and the number of labs doing it has reduced due to the changes in the HPV on there. But we've still got people going through that qualification. We could have 10 more people sitting the exam in next month on that. And then we've got the diagnostic cytopathology qualification as well, or non-gynae cytology as it used to be called as well. Now, the ASD in that has existed for less than 10 years on there. Numbers are relatively small, but we have got people going through the DEP, and we're expecting a tick up in the growth of the ASD in the next couple of years as well. So there are people already going through the qualifications and therefore working in consultant level roles, particularly in, as I mentioned at the start, in dissection and cytology, and we'll talk about those more shortly as well. I think it's worth saying, and apologies for those of you on this call who are not in England, but but for those of you who are in England, the recognition of the importance of this qualification, or the ASDs and the funding and the important roles individuals will have, is shown by the commitment that at the time the HEE on there, obviously it's changed subsequently, had provided to funding to support employers of individuals doing the qualification, and that funding has equated to around £1.5 million. So that's a significant amount of funding that's being made available to employers of candidates in England undertaking any of those listed qualifications. Funding is available. There's posted details about how that funding can be claimed. It's on the website. That's still available for at least this year, hopefully into next year as well on there. It is interesting sometimes that we hear that there is no money for there's no funding for training. Well, there is. That's not always very well claimed by the employers, but there is that funding. The amount that's available depends on the qualification, and I can put details about that in the chat later as well. Again, just very briefly on here as well, we have got 2 position statements that are currently on the website. They are being looked at again to make sure to update them, to revise them slightly, just in terms of some of the terminology used in them. But this gives you an idea of the potential level of banding, AFC banding, for individuals undertaking the roles. As Jane touched on earlier on, you may have different titles and different, slightly different terminology used within your own trust around it. And I know from speaking to some people on reporting qualification, a number of people have gone through matching exercises to get their pay bands. So this is not a hard and fast, you must be at this level. This is a statement of guidance more than anything else. And that's here for the reporting roles. And similarly, there is one for dissection as well. And that just shows that there is that growth in that role as well, and the sort of roles that people are expected to have for these qualifications. I say terminology in terms of the actual title you may have will vary depending on where you are and local variations, but it gives you a broad understanding of the sort of level people are expected to be at as well. So we've talked briefly there about some of the qualifications there. Before we hear from the couple of colleagues who are joining as well, I'm going to hand back over to Jane for a couple more slides around some of the challenges in terms of the process as well, because there are some, I think it's fair to say. Jane.
Yes, thank you, Chris. Yes, I won't keep you too long because, as I say, we need the experts from histopathology here. As already touched on, first of all, is that identification of need. One might want to look at developing a more clinical focused role, but in terms of actually looking at consultant roles, there's going to have to be a need for it. So that's going to be in conjunction with discussing with your local pathology management and local consultants as to where these opportunities exist, and then moving forward from there. It needs to be part of a multi-professional workforce planning, which I've touched on before. I think one of the biggest things is acceptance of new roles. This is changing time, and as we said, there's evidence now from many organisations and NHS that actually have identified the real benefits of consultant scientists to patient care and delivering the NHS plans. But at a local level, then people's experience can be quite varied. So it's like any change, it can be difficult. So you might find that you do get a lot of support in one area, but you might find that in other aspects, it's you have a little bit more of an uphill struggle. But as I say, it's new, and as more of these roles come into practice, then these sort of changes and then are more readily embraced, and at the end of the day, hopefully all the patients benefit from this. One of the big things is, and I think moving on from perhaps where we are exactly at the moment, is where these roles have been established, it's trying to sort of, I guess, change the culture a bit, that they're established within the department and not the individual. I think with any new role at the moment, it's seen very much that this role goes with this person. And I think one of the challenges moving forward and keeping the momentum and where these roles have been established, and I say colleagues coming on next will say, it's a lot of work to get these, from having the experience and doing the qualifications, it's a lot of work to actually get the roles. Having achieved that, it would be nice to think when these particular people in post move on for whatever reason, that we have succession planning and we've got other people coming up behind, so that we're not sort of reinventing the wheel and having to sort of re-establish the roles each time there's a staff change. So I think those are the sort of the main points I'd like to make on that. Next slide, please. And I won't go through all of this, but at the end of the day, your clinical experience doesn't just arrive in your lap on the day you decide to you'd like to become a consultant. Your clinical experience comes from years of building up knowledge. And whether or not you want a clinical role, at the end of the day, we're biomedical scientists and we look after patients. So the clinical aspect should always be sort of quite pivotal in our psyche and what we're interested in. But if you are looking at developing a very strongly clinical-based role, then you do need to learn the clinical elements about all the work you do as early in your career as possible. A, it will make it very interesting, but B, you start building up the background knowledge based on individual cases, and where you can go to meetings, where if you can get yourself invited to MDTs, do anything where you're going to be exposed to a wide breadth of discussion on the clinical aspects of your particular discipline. And then at some point, you probably need to make a career decision as to whether you want to do clinical more or whether you're going into pathology management. If you're very lucky, you might be able to do both, but I think those days with the volume of work are getting few and far between. But whatever you decide, good luck, and I'll pass you back to Chris.
Thanks very much, Shane. So thank you. We're going to hear now from Rachel and Monika, who have, as it says in here, have both done the, Rachel's done histological dissection, reporting qualification, Monika, cervical cytology. Unfortunately, Madeline Stevens, who was going to be hopefully joining us today, has been unable to, just to have personal issues as well. But what she has done is she has sent me a presentation that she delivered at Congress about her experience, and has said she'd be happy to share with that. So I will ask my colleagues who are set up this call to share that with you as part of the outcome of this meeting as well. So I'm going to pass firstly to Rachel, just because she's the first on my screen. In terms of, it's just briefly about her experience of it as well. So Rachel, over to you. Thank you.
Hello. So hopefully you can see the presentation that I've put on the screen.
Yes, thank you, Rachel. Yeah.
Super. Okay, so this is just a brief introduction of myself. So I'm currently working as a consultant biomedical scientist, and I'm a band C, and I'm working at West Suffolk Hospital in Bury St Edmunds, and this is a district general hospital. And all of my practice over the 33 years of being a biomedical scientist has been at district general hospitals. So I want to stress this, that don't think that because you don't work at a teaching hospital that you're not going to be able to do these qualifications. In fact, from my experience, what it has meant is I've been able to deal with a massive range of specimens rather than just specialising down a single route of just the GI dissection or breast dissection. So even now I dissect specimens, all specimen types, and that I think is a huge advantage of working in a DGH. So as you can see, I was actually in the first cohort that did the DEP all of those years ago. And the bit in italics is just what the IBMS have as the eligibility criteria for these qualifications. I then went on to do the advanced specialist diploma in breast dissection, and I actually failed the breast dissection qualification on my first go. So this has not been plain sailing by any way. And I have to say, failing the ASD was one of the things that hit me the hardest as an individual. I wasn't used to failing qualifications, and that hit really hard and was really painful. But you pick yourself up and you carry on and try again. And then I didn't actually finally pass my ASD in breast dissection until I was also doing the GI reporting. So I resat the first year of my GI reporting qualification. So I think for me, what I have is I have a really unique crossover between a technical role and the clinical role. As you can see there was part of my time I was the department manager whilst I was also the advanced practitioner in dissection. And this unique crossover in the role has been really beneficial to our department, because although I still do the large specimen dissection and dissection lead, it's also allowed me to continue with some management roles. And as you can see at the moment, I'm currently the UCAS laboratory director for the department. And I've been the HTA DI for the trust. I'm now just the nominated person for pathology. And then I have my clinical responsibilities as well. And as was said previously, I lecture at Essex University too in breast, colorectal and gynae, but I was actually part of the team that set up the degree at Essex University. So by moving into these roles, I think it's important to not forget where you've come from and still use those skills that you have behind you as well. You know, you're becoming a senior member of staff, and you need to utilize everything and also lead from the front, you know, show other people from your experience, you know, what they could achieve and give them the support. Because if I hadn't had support from people, my pathologists, but also from the department managers and also from all of the technical staff, right down to the MLAs with doing these things, I wouldn't be where I am today. So I think don't forget the people that you work with and that are behind you. So as been said before, remember you are moving into a clinical role. These tend to be the senior banded roles. And as you're moving into a clinical role, you need to act the part, act professionally. And even though it sounds bizarre in this day and age, dress professionally as well. So, you know, you are trying to move yourself into a circle with the pathologists. And so like look at them and see, you know, what they are doing, how they're addressing, how they behave, who they meet with. You need to sell yourself. And you need to earn the respect of the technical staff in your department and also the pathologists within your department. You will meet people who are not accepting of advanced BMS roles, even now, even though they've been going all this time. And I think a lot of that is about that they don't understand what they are, what they involved, and the perceived threat that you have to their roles. And that isn't there. You're part of the team to provide this service. And I think that's what you need to get across to them and prove to them. And as has been said, use clinical terminology, use these in your macroscopic and microscopic descriptions, and in your portfolios, use these in your case discussions and your case studies. And also one of the things, because I mark the exam papers, use these medical terminology in your exams. You know, don't use layman's terms. You're trying to prove yourself here that you have this knowledge. So, you know, this is what you need to develop over your training and experience. As with everything, communication is absolutely everything. And this is communicating at all levels with everybody. When I went on to do these advanced roles, I went to the huddles in the morning and talked to the technical staff about what I was wanting to do, what this would involve, what help I might need from them. Of course, the department manager you need for their support. But also I went round to each pathologist individually and I met with them and I talked through the curriculum with them and what training needs I might have from them, the support and assessments, and what the advantages of you doing this qualification is for the department. And what this meant was the pathologists, they could express their concerns, their fears to you. And then if they then wanted to have the opportunity to then go back and speak to the clinical lead, then they could have those discussions away from me as well. But they had that good understanding. And going to the MDT meetings, you need to get in with your clinical team. So get your face seen at the MDT meetings, and be responsive to the clinical teams if they're asking questions about dissection or if there's a problem or they want a specimen expediting, be responsive to that. And it's the development of these relationships that are really important for your future progression through these qualifications if you go on. So these are really important things to work on. This is one of the things that I've learned from my experience. Have a plan, a written plan around your human resource. So when you come off your qualifications, you know whether there's going to be a post for you or whether you're going to have to apply for a post or what your title will be on completion of your training. And I particularly fell foul of this when I did my reporting qualification, because this wasn't in place. And what it resulted in was I went through an 18-month process of job matching to once I completed my qualification to be made up-banded and to be able to reflect the qualification that I got. And at that time, it was said to me, this should have all been put into place at the point that you started reporting, so that you knew that there was something at the end of it, or that you knew that we would have to create a post at the end of it, or that you knew that you were going to have to look for a post elsewhere. So, and if you have this, then it takes that uncertainty away from you, but it also helps the manager with workforce planning and things like this. So I think this would be something that's very well worthwhile trying to pursue at the start of your qualification. So one of the things I get asked the most about is professional portfolios. And although there's much more freedom associated with doing the professional portfolio in comparison to the registration and specialist, just really refer back to the curriculum that is in the logbooks. Everything you need is there, and follow that plan. Keep to the word counts. If it says that a case study should be 1,000 words plus or minus 10%, don't produce a case study that has 400 words in. We will just fail it. So everything you need is in that logbook to guide you through doing your professional portfolio. Again, put a lot of reflection in about your experiences, about the things you've done, the things you've learned, and you're going to be there. You're trying to showcase what you know and your experiences. And I like it when I get a portfolio that has a brief introduction about yourself and where you've worked, how long it's taken you to get through this qualification, and a bit of overall reflection on the, you know, the experience of doing your portfolio. Be proactive. You have got to drive yourself through these qualifications. Do not expect just to sit back and have people hand this to you on a plate. This is a sort of a quite unique opportunity. These posts are limited, and you need to be self-motivated. You can't just say, I haven't been given my study time at work to do this. You need to be prepared to give up evenings and weekends and go into work out of hours to do this. You will not achieve these higher level qualifications without doing this. And if you are really driven to want to move into these clinical roles, then you will do this. And you need to expect to do this. This is not going to be handed to you on a plate. These are hard qualifications that need work putting into them. I cannot stress that. I was lucky. I don't have children. I was doing these when I was a bit more mature as well. My partner works in the laboratory, so he was fully supportive of it as well. But I lost hours and hours, or spent hours and hours and hours looking at slides, writing up things for my portfolio in my own time. So I say, and you have to do case reviews at all levels of these qualifications. And although you want to sit down and do these with pathologists, there is nothing stopping you taking cases yourself and looking at the reports. And then if you have questions, then you can go back to that pathologist and ask some questions. And again, like if you're coming across a specimen you haven't dissected before, read the SOP. Don't just stand there and wait for this information to be given to you. You know, impress. Let's say you're trying to impress, be proactive and do some of these things yourself. And that's my guidance from my experiences.
Thank you very much, Rachel. Well timed. I was just about to say on there, so thank you for that. Monika, do you want to just briefly talk about, just conscious of wanting to leave some time for some questions as well, but if you just want to give a brief overview of where you've gone, your experience as well from a cytology point of view as well. Although you appear to have frozen. I know you're back. You thought you'd frozen on your screen, but you're back, so that's okay on there. You're on mute at the moment, Monika. That's it.
Right, I'll try to be as quick as I can. Yeah. Hi, everyone. My name is Monika Bhardwaj. I'm Consultant Biomedical Scientist within Cervical Cytology Laboratory based at Royal Wolverhampton Hospital. I've been in this role from the last 2 years, and collectively I have 16 years of experience within cervical cytology. I started as a trainee BMS, and again, as Rachel mentioned, my training also been in district hospitals, not in a teaching hospital. So it is possible to go through all these qualifications within district hospitals. I started, as I said, my training as a training BMS, and then after passing my qualification as a screener within cervical cytology, at that point I was allowed to screen the cases which are negative, and the abnormal cases are normally reported within cytology, either by pathologist or consultant biomedical scientist. Within cervical cytology, there's been a few merges throughout since I've been in this discipline, and due to those two merges, I moved from my original hospital where I started my training to a regional district hospital where I completed my specialist portfolio and also progressed to the role of senior biomedical scientist for several years. And back in 2019, where cervical cytology also had another major consolidation, there was 45 cervical cytology labs within the country, and they all merged into 8 labs from 45. So, and at that point, there was lots of issues like every other big merge. And one of the issue was lack of staff who could report cytology, including pathologist and consultant biomedical scientist. So at that time, there was this opportunity arose for more biomedical scientists to be trained as consultant BMS, and I put myself forward. That was just at the start of 2020. So as my training started, 3 months later, due to COVID hitting, the training halted quite quickly. There was no training at all for nearly 4 or 5 months, and then we repicked the training. But at that time, there were so many challenges, including backlogs, staff sickness, and at the same time, I was going through quite a few personal challenges as well. We started a massive house renovation at the same time. And then having 2 young children as well, it was very, very challenging. The qualification of ASD in cervical cytology involves completing portfolio of evidence, and once you go through that portfolio, once it's successful, then you can go ahead and then do your written exam and also your microscopy exam as well. You have to pass all those 3 aspects in order to gain the qualification of consultant BMS. And then if I just quickly talk through my day-to-day role, my role within cervical cytology involves about 5 to 6 hours of your time sitting and doing microscopy. And the role of there are several responsibilities, but the main one within cervical cytology is to report abnormal cases independently, offer expert professional advice on patient management and follow-up, and participate in training of biomedical scientists and specialist trainee medical staff in the reporting of normal and abnormal cervical cytology samples. One thing I just want to mention, within cytology, when you are as a BMS, you can report the normal cytology cases, whereas the abnormal cases are passed on to consultant BMS or pathologist. At that time, the grading of the samples, there will be somebody else at the end will be looking and will be responsible for the case. Whereas once I've got my post as a consultant BMS, like anything else, it was very nerve-wracking, very scary to know that you are the last person now where the report will be going out, and you feel that weight of responsibility that your actions, your decision will directly impact that patient at the end, how they will be managed and how they will be treated. So that sense of that responsibility that you are the last person will be signing out this case. And the other crucial part of the CBMS is to participate and contribute during the multidisciplinary meetings, where all the services responsible for patient care have discussion to ensure the best outcome for the patient. And due to the service at the moment, we have about 15 colposcopy units within the whole of the West Midlands. And we have on site 4 consultant biomedical scientists and 2 pathologists who share these meetings, which can be twice a month or month with sometimes 50 cases at a time to review and to discuss their management.
Okay, thank you,
thank
Monika. That's
okay.
okay. No, thank you very much. Thank you, Monika. We appreciate that. And so we've got about 5 minutes left or so, just for some few questions. And those of you who are on the call see Sue Jones, whilst we've been chatting, has been putting some links into the chat as well on there. So links to the statement I was talking about, the funding, and a couple of our workforce plan as well. So thank you, Sue, for doing that whilst we've been going along. There's been a few questions. Either Jane, Sue, or I will just pick these up as we go along in the chat, and then if anyone wants to say anything else, then they're welcome to as well. There's a question around prescribing rights for biomedical scientists in microbiology. I have to say I don't know the latest on that on there. So I'll come back to that one and get the colleagues. If anyone else has any better news on that one, on there. There's a question from Gina around the numbers doing the other qualifications. I can say that for immunocytochemistry, I've just looked, we've had about 40 people achieve the immunocytochemistry DEP. Mohs hasn't had anyone take it yet. There hasn't been a huge number of take up for that at the present moment in time. There's a question from Sarah Copsey about the HSST route, whether that's only available in microbiology. I believe it's also in other Jane's not shaking her head, so Jane will be, there's also available in other disciplines as well. Jane, did you want to?
Yeah, it is available in all the key disciplines, and on the national school, well, that's right, with national school website, then there's a discipline plus the entry qualifications are all detailed there.
Sarah, you put your hand up at that point. Did you want to ask a question just at that point on there?
Yeah, it wasn't so much that whether that was available for other disciplines. It was, is that the only route available to achieve this at this point, rather than via yourselves, for example.
Okay. Well, I mean, did you want to say anything to that, Jane?
I think the HSST, as far as a formal qualification route at the moment at consultant level practice, that is the model that's there at the moment. But as a consultant's level practice within haematology and for existing biomedical scientists, as I said, they've gone through a variety of routes in terms of experience, professional doctorates, and evidenced other consultant equivalents. And I think that's probably, I don't think I can say much more on that, but obviously the HSST is a route there if that's something that a route somebody wanted to go down.
Thank you, Jane. There's a question here from Adela about whether it's possible for BMS to be a PhD holder as part of a career development. I mean, yes, a biomedical scientist can do it on there. I mean, that takes time, and there's a lot of long-term commitment to that in terms of that. But on there, it's probably it's unlikely that there's many careers that you need to have a PhD to be able to do it on there. But yes, a BMS can do a PhD as much as anyone can as well on there.
Can I say something, Chris, there?
Yes,
I was going to answer the question, but I thought I'd let you answer it. We have people who've come in through the equivalence route to become biomedical scientists who have done exactly that. So they've had a research career or had a PhD and worked in different laboratory settings, then worked in clinical labs, and they are biomedical scientists who are registered who do have PhDs. So you can start and do one, or you can have one and come in.
Okay, and then there's related questions from Emma and Philippa around the routes as well. So one from Emma around, do we need to be registered as a clinical scientist to work clinically on there? And the answer to that is, as Jane shaking her head, no, no on there. But sort of links into how do these roles differ from the clinical scientist route. It is an alternative. It is an alternative route, aimed specifically at those of you who are biomedical scientists as well. So there's no need to gain dual registration as well on there. And is there scope for the BMS to have a greater impact work with the school in the delivery of HSST? I'll leave that one there. I don't know. I'm not going to answer on that one. I'm not sure of any plans at the moment around that as well, because the school is a separate entity, as it were. I'm just scrolling down.
Next one, I think, is Philip has asked about how does a clinical scientist role differ to a consultant biomedical scientist? Yeah, I don't mind. Who wants to take? No, Jane shaking her head. Is there any difference?
I think, as we said before, is that all of these roles are very much a case on need. So, so any consultant level role, the job description is going to be sort of relevant in view of what the job role is going to be. But as Chris has already highlighted, there isn't any restrictions in terms of registration. So whatever consultant level practice is deemed necessary in the organisation, then if you're a biomedical scientist, the job description could reflect that.
Can I add that if you do have to go through a job matching process, there isn't an agenda for change profile for a consultant biomedical scientist. You are currently matched to the clinical scientist job profile. And if I believe correctly, the Royal College of Pathologists on their website do say that they are considered to be equivalent level roles. So, but just to have that awareness.
Thank you, Rachel. There's a question from Martin. Welcome, Martin, on there around obviously positive there, but is there any development on the HCPC standards of proficiency to explicitly state that biomedical scientists can, for example, identify the clinical decision? I've
just said to Martin, the fact they've only just updated them means they're not going to update them anytime soon. So they updated them last in 2014 and then again in 2022. So there's about 6-7 years between them updating normally. I think the information they have been told is that biomedical scientists don't always have patient contact. So I think they were trying to balance between giving standards people can't meet and then giving standards people can meet. So when I've discussed things with them and said, if it's somebody who's doing their training, who's going to go onto the register, they may not have direct patient contact. How would they evidence? And they've said it's in their context, it's context dependent. So you could be a clinical biomedical scientist, consultant biomedical scientist and do clinical work and see lots of patients, and you would evidence that and you could make it fit. If you are somebody who's quite early in their career and don't, then you can still demonstrate that you meet the standards of proficiency with the wording that we currently have. So I think that's why it's not so clear, Martin, that we're trying to be kind and not give us things that not everyone can meet.
Thank you, Sue. So a question from Philippa around the proposal for the microbiology qualification. It's in early days, I would say, on that one, but yes, it's likely to have a common core, and then specialisms as well. So similar to the hematology one and all the dissection one. So recognising, as you say, that some people might be in infection prevention and control, and some people might be in antimicrobial resistance. So yeah, there will be different routes through that qualification as well. Keisha has a point around the training for the DEP and diagnostic cytopathology. I think I want to stress on that one is you say about the training only being available in one place. I must stress that that is an additional training course for the qualification on there. So it's not compulsory to go on that course. I think you're probably referring to the NEPSEC course on there. That's an additional course to support the training that your own lab should be doing in getting you through the qualification. So it's not that it's the only place that's doing the training. That's an additional training course that's been put on to supplement those who are doing those qualifications, to help prepare you for the exams and things like that on there as well. It's delivered in the way it's delivered by NEPSEC. That's their choice in the way they deliver that course, but it's on there. Other organisations could lay on that course if they wanted to, but NEPSEC up in Wakefield have long since been running that course as well. I am conscious that we've just gone over, but I'm just going to scroll down to see if there's any other immediate questions.
There's a question for Rachel, which is about the ASDs, because you did two, Rachel. So the question is, if you had your time again, would you do them both? I think, essentially, or would you choose one over the other, and why?
So I did the ASD in the breast dissection, should I say, and then the ASD in the GI reporting. So they were sort of effectively two separate qualifications. I think as part of the ASD dissection qualification, now it's much broader scope. So you don't have to just do a single specific entity. You can do sort of like breast, GI and gynae if that's what your practice is. So I think that's an excellent way of sort of like opening up those pathways for you. Would I do all my exams again? I would do, yeah, because they've given me the career ultimately that what I wanted. They were a lot of hard work, but it has given me the best career that I could have wanted as a biomedical scientist. So yes, you don't get anything without hard work.
And Dana, going back to your point, I think you're the one who asked about the PhD. There isn't information on the Institute website about PhDs. If you're interested into PhD, that's something you would need to look up yourself in terms of what's the most appropriate PhD for you to do, depending on what your interest is as well.
And who the supervisors would be. So it would need to be linked to a university. So if you think about your local context and where you're based, you could put out feelers with your local universities and ask if that's something they might be able to facilitate, possibly. And then Uday has asked a question, or Arinze, sorry, has asked a question about from transitioning from academia. So the HSST isn't an IBMS qualification, so I'm afraid we can't tell you any more information about that because we don't run it, do we, Chris? But if you ask the national school, then hopefully they'll be able to give you some information on that. And then Jacob has asked about membership. You can be a licentiate member of the Institute whenever you want to, Jacob, if you meet the criteria. So you can be a member of the professional body if you're not in practice, because we have a student membership grade as well. So if you wanted to join the IBMS, you'd be very welcome to do so. You don't need to be in a lab to do that.
Thank you very much. Okay. And Jose, did you have a question? Did you want to? Arinza? Sorry. No. Okay. Okay. Well, thank you very much, everyone. Just to finally conclude, I think hopefully in this session, which I know we've gone slightly over, so thank you for your patience on that, is that, as you can see, there's a lot of work going on by the Institute. There's a continuing and growing acceptance of scientists undertaking consultant level roles. I think as Rachel and Monika, and thank you to Rachel and Monika, have said, there are challenges in becoming and taking on these roles. It's not an easy task, so on there it's quite a lot of work as well. And we'll be continuing to develop our work in terms of more qualifications and more options as the work goes on as well. So hopefully that has been a useful session for you all on there. And I thank you for your time this afternoon. Thank you, Jane. Thank you, Sue. Rachel, Tarina, Monika. I was about to miss one out there. Thank you all, and I hope that was a useful session for everyone this afternoon. So thank you, everyone.
Brilliant. Thank you, Chris.
Thank you.
Thank you.
I put information in the
Thanks,
chat on where
Chris.
to get the videos as well, if anybody wants to get the
Oh
videos.
no.
You can watch yourself back, Jane. You can enjoy the spectacle.
I don't think I want to watch. I don't think I want to watch myself on screen. I don't.
I hate it. I hate it.
Sorry, guys. Before we go, can I ask a question? I realized I was talking, but my mic was muted. Sorry about that.
Okay.
So the question I asked about transitioning, because I'm a fellow of IBMS now, I'm a lecturer, but I try to do the portfolio as well to become a consultant as well, by the, in line with what I'm doing as a lecturer. But I've tried. I know you mentioned the academy. I've written to the academy. I've written to IBMS. I've written to Royal College of Pathology. I keep getting the same thing. It's just like I've been going round and round and round. So I wanted to know if there's any like straightforward answer to know if this is doable or not.
I'm afraid we can't tell you because it's not our qualification. So if you contact the Institute, you probably won't get the answer. It is the academy that you need to get in touch with. If you meet the entry criteria, then you need to find out why, don't you? It may just be it's very competitive and they only have certain people doing it. So, but yeah, I would ask for feedback, be persistent.
Yeah, I've actually, like I said, I've reached out to even everybody, ACBC, the academy, Royal College, but they kept on going back and forth. But from what I'm getting, there's always direct entry every year, and for the past 1 or 2 years, there hasn't been anything like that on the consultant route.
Okay.
But is it doable? Like, has anybody ever done that before?
I'm
oh, okay.
We don't know the answer. You need to ask the academy, I'm afraid. Sorry.
Okay. All right. Thank you.
Thank you, Rita. Thank you.
Has anyone else got a last question before we wind up? I can see still a few people on the call, but if nobody's got a question, nothing in the chat, Chris?
No.
Anything else appeared?
No. Just have a check.
No, just lots of thank yous.
Okay.
Yeah.
Okay. Thank you, everyone. And I hope that's very useful to everyone. And thank you for your time this afternoon.
Yeah. Thanks, everyone.
Thank you.
Lovely to meet you.
Thank you.
Bye.
Thank you. Bye.